We're grateful for your tuning into this third webinar and hope you've enjoyed the series. Many of the participants have asked if this will be available as a recording in the future, and the answer is yes. However, the Mayo Clinic owns the recording, and at some time in the future, they will make this available as a CME. So just stand by for future information on that. Just as a reminder, our fourth webinar will be this Thursday at 5 p.m. Eastern Standard Time. Please consider joining us. We'd love to have you. And again, a big shout out to our sponsors, Boston Scientific, Carl Storz, Coloplast, Sonomotion, Bard, Olympus, Dornier, Richard Wolf. These partnerships are really key for our educational missions, as you know, and we are really grateful for all that they're doing and their support. So if you have an opportunity, when you see these reps from these companies, please thank them. And if it's possible, give them an opportunity to help them grow your practice and show you the new innovations that they have. I think that would be a nice gesture towards showing our gratitude for their partnership in this educational mission. A couple of housekeeping items here. The chat function is only for the panelists, and the Q&A will be for anyone who wants to ask questions, and we'll be taking questions throughout and trying to answer them. However, at the very end of the webinar, we'll have some time to do a complete Q&A, but feel free to use a Q&A. The chat, again, is only for the panelists. Do not use the chat. I think I blocked that, but also throughout this webinar, we will be polling questions for each session. Feel free to answer if you want. We'd love to see your responses. Many of the polling questions are essentially simply questions about your practice and how you see that the topic incorporating into your practice. I'm going to have a little change up in the lineup here. Dr. Pace got called away for an emergency, but he will give his lecture later on this morning. So instead, first up will be Professor Dirk Lang from University of British Columbia. He'll be talking about stone disease, scientific review, the microbiome, and microbiology. So without further ado, I'm going to give it to Dr. Lang.
Great. Thank you so much, Roger. So I've been tasked to talk to you a little bit about microbiome and microbiology, so something a little bit different from the usual purely clinical talks. And so these are my disclosures, and none of what I'm talking about today has anything to do with what I consult on. So I'm sure that most of you have heard about the microbiome in one context or another in the recent years, especially its role in the maintenance of overall health and how important it is. And when compared to the cellular composition of the human body, the magnitude of this microbiome becomes very evident. So, for example, the human body harbors 10 times more microbial cells than human cells, which is approximately 36,000 bacterial species and trillions and trillions of cells. And when you look at it on a cell-by-cell basis, that means we're technically only 10% human. When looking at the protein level, the human genome encodes for 30,000 proteins, whereas the bacterial genome in the microbiome encodes for 3 million protein coding genes. So on that basis, we're 99% bacterial, which is quite extraordinary. And so when looking at just how much we truly are bacterial, all of these bugs must collectively serve some sort of function. And as it turns out, one of the most important roles of the gut microbiome is that it enhances our metabolism. They essentially produce proteins that we do not have, and therefore it provides us the ability to break down and or extract compounds from foods that we require but don't otherwise have the ability to chain and utilize. So this is a very, very important function. So really, it doesn't come as a very big surprise that there's a potential role between the intestinal microbiome and recurrent kidney stone disease, as diet is a contributing factor to recurrent calcium oxalate stone disease. And Back in 1985, Milt Allison and colleagues discovered a bacterial species within the intestine of animals, which is quite extraordinary in that it gets its energy solely from breaking down oxalate. And most bacteria have other ways of getting energy for growth and survival. But this bacterial species' main source is oxalate. So subsequent clinical studies showing that recurrent stone formers were less likely to be colonized compared to controls suggested that we had indeed found the answer of why patients form stones, especially recurrent stones. But subsequent, these clinical trials suggested that patients were less likely to be colonized by this bacterial species compared to non-stone forming controls. However, as more and more clinical studies were performed looking into the role of this Oxalobacter, the more data accumulated suggesting that Oxalobacter formigenes alone was not the answer. So, for example, when you look at these studies, the range of colonized patients or the range of colonized non-stone formers is very, very broad. In only about 55% of studies, colonization with Oxalobacter formigenes only resulted in lower urinary oxalate levels. And when Oxalobacter formigenes alone was given as a probiotic, it didn't reduce urinary oxalate excretion despite colonization being present. So this seems to suggest that, Oxalobacter formigenes doesn't appear to be working alone. And support for this came from a clinical study looking at the presence of other oxalate-degrading bacteria in the feces of black and white South Africans based on real-time PCR quantification of oxalate-degrading genes. And essentially, this showed that microbiomes of black South Africans degraded greater amounts of oxalate on the same diet over a 120-hour period, contained similar numbers of Oxalobacter formigenes to the white population, but the black population had greater numbers of the oxalate-degrading species Bifidobacterium and Lactobacillus. And so this was one of the first studies to suggest that Oxalobacter formigenes to hang out with, play around with, and maintain overall healthy oxalate homeostasis. A subsequent in vivo study looking at oxalate degradation on normal or oxalate supplemented diets of wild type or AGXT double knockout mice, and these mice suffer from primary hyperoxaluria, showed that when you colonize these mice with Bifidobacterium strains, this resulted in lower urinary oxalate to creatinine ratios, further supporting a role for species other than Oxalobacter formigenes in breaking down oxalate in the intestine. Thinking that we'd once again discovered the answer, clinical trials involving probiotic supplementation with Bifidobacterium and Lactobacillus were launched. However, just as is unfortunately more often the case, there were mixed results, with some showing no changes in oxalate absorption, while others showed decreased absorption only while patients were actively taking the probiotics. And so this indicates that transient colonization was a significant issue. And that indicated that simply trying to put the missing bugs back doesn't work. And kind of, if you think about it, makes a lot of sense, because expecting bacteria to thrive in an environment they didn't survive in to begin with just doesn't seem to make a whole lot of sense. So there's obviously a bigger story to this. So this gave rise to several studies that, started looking beyond Oxalobacter formigenes and oxalate degraders alone. And these studies looked at differences in microbiome composition overall between patients and controls. And what these showed was that, for example, Bacteroides, Enterobacteriaceae, and other groups were enriched in patients, while Prevotella was enriched in non-stone formers. But all of these studies focused on the presence or absence of individual groups, while none studied the existence of actual bacterial networks, so bacterial teams, if you will, that are important for oxalate metabolism, which is important in a highly symbiotic environment such as the intestinal microbiome. So we recently completed a study, or performed a study, where we compared the intestinal microbiome composition of 17 recurrent kidney stone formers and 17 non-stone forming controls. There were no differences in the intake of nutrient or dietary parameters in these individuals after analyzing that have a foregut microbiome that specialize in oxalate breakdown. And these rats are actually able to break down up to 12% of oxalate, which a human would not be able to handle very well. So through some very nice oxalate supplementation studies, this group was able to identify a network of bacteria that increased or decreased in abundance with Oxalobacter fumigines following exposure to the different diets and formed an oxalate degrading microbial network. And this contained or included Oxalobacter, Lactobacillus, Clostridium, and Enterococcus, just to mention a few of these members. So now that we had some sort of an idea of what one of these bacterial networks around Oxalobacter might go, went back to and compared the rat bacterial networks to the composition in our human samples and found overlap existed. So, for example, the Taxiruminococcus and Aspira were present in non-stone formers, were associated with the presence of Oxalobacter, and were stimulated by oxalate in the rat studies, suggesting that an oxalate degrading microbial network does exist in humans, at least to some extent. The fact that taxa such as Bacteroides, De Silva vibrio, and Anorostipes were present in non-stone formers only, and but were stimulated by the bacterial network may be important for overall oxalate homeostasis as well. What does this all mean? It's nice to know what bacterial species are more or less. Look at it. Okay, so what? How does this translate into functional differences? Because you need to look at the metabolic capabilities of the microbiome. Sorry about that. Am I still on here?
Your slides, you're no longer sharing your slides. You're just sharing your picture of yourself right now.
Okay. Okay. We should be back now.
Yep, there you go.
Okay, sorry about that, folks.
It's okay. And we're about 5 minutes away if you just give you a little
no, I'm good. Yeah, thank you. So we need to look at the metabolic capabilities of the microbiome as a whole, because that's what is showing the presence or absence to an actual effect in microbial function. And so to do this, we performed shotgun sequencing to identify some differences in actual metabolic pathways that distinguish the patient population from the controls. And we identified 3 different ones. One was antimicrobial drug resistance, which actually supports previous findings that increased antibiotic use increases stone recurrence. And I'll get back to that in just a couple of minutes here. Another pathway was xenobiotic degradation of metabolism, and then glycan biosynthesis and metabolism. We decided to focus on the last one, mainly due to its relevance to oxalate metabolism. So we decided to look at metabolic pathways involved in oxalate metabolism for obvious reasons. We also included pathways that looked at glyoxylate metabolism and ascorbic metabolism due to their role in stone disease. And we also wanted to look at butyrate metabolism because it is a key factor in determining intestinal membrane integrity. So of note, we didn't find any differences in abundance of bacterial genes associated with oxalate metabolism, which suggests that overall, there was no difference in the ability for patients or controls to break down oxalate. There were also no significant differences in the abundance of pathways between recurrent stone formers and non-stone forming controls, and no significant difference in completeness of each of these metabolic pathways. However, when you looked at the abundance of specific genes, we did find a lower abundance of 6 different enzymes involved in butyrate metabolism, which suggests that the capacity for because this was, first time that there was some data to suggest that other mechanisms might be at play here. But what got us was Philadelphia was performing a similar studies on children between the ages of 14 and 18, and they showed that there was 18 taxa lower among stone formers, and most notably, there was less butyrate producers, and they also found no difference in oxalate degrading capacity, and most excitedly also found a decrease involved in butyrate metabolism. We also found be in lower abundance in the population. So this it supports in adults what may be happening outside of just oxalate degradation. So what about butyrate? Well, again, the proven, of course, but butyrate promotes intestinal health by regulating epithelial tight junctions and overall leakiness of the intestinal epithelium, and also upregulates the expression of key intestinal transporters, some of which are known to also be able to transport oxalate. So it's quite possible that decreased oxalate absorption due to more permeable intestinal epithelium and changes in transport expression. But again, the data so far actual oxalate absorption. So what causes microbiome dysbiosis? And so basically the disruption of the overall composition of the microbiome. Well, as I suggested earlier, there's a couple of studies come out.
Hey, Derek, we lost your presentation there.
Again, okay. Should be back there.
There you
go. So there's greater odds of kidney stone disease with oral antibiotic use up to 5 years out. And there was greater odds of developing kidney stone disease with recent exposure at younger ages. A similar study on 5,000 women in the Nurses' Health Study concluded similar findings, which was that antibiotic use greater than 2 months in early adulthood and middle age increased the risk for urinary stone disease later in life. So antibiotics do clearly show intestinal microbiome composition. Nutrition, of course, just actually just published this year that showed when you have different nutritional changes in your diet, high salt intake, high animal protein intake, high oxalate intake, low calcium intake, and so on and so forth. This not only has effects on urine chemistry and lithogenic risk, but it also has significant effects on gut microbiota composition. So to conclude then, dysbiosis of intestinal microbiome has a definite role in recurrent kidney stone disease. Overall oxalate homeostasis does seem to involve a network of bacteria working symbiotically in conjunction with Oxalobacter formigenes. There's also some results that suggest that there's also Oxalobacter independent networks. And dietary habits as well as antibiotic use results in the loss of overall intestinal microbiome function, where the loss of bacterial species results in decreased oxalate breakdown and potentially butyrate synthesis, or a gain of function dysbiosis, where an increase in bacterial species changes the environment to increase oxalate absorption. So with that, thank you for the opportunity, and I wish everyone the best of luck and stay safe.
Thank you so much, Dirk. Really appreciate it. I'm now going to give my talk on infectious complications, which is a nice segue from your discussion about the microbiome and the infectious complications and how we can minimize these. These are my disclosures. So I think probably one of the most important things for you to take away from my talk is how do we use antibiotics judiciously? Because this is a problem that we're encountering. This is an interesting survey that was done at Duke. They surveyed many urologists throughout the country, and they asked them if a patient had a negative pre-op urine culture and was going to go for a ureteroscopy, how much antibiotics would you give? Would you give a single dose at the day of surgery, or would you give more than a couple of days of antibiotics prior to surgery? And the majority of people answered that they would give a single dose, which is in line with the AUA best practice statement. They then asked the same question if the patient was going for a PCNL and had a negative pre-op urine culture, how much antibiotics do you give? And the majority would give a single dose at the time of surgery, though a good proportion of urologists would give it more than at the time of surgery. They give a couple of days or a day before surgery. And then a different spin on it was, what if the patient was going for a ureteroscopy but had a positive urine culture prior to surgery? How much antibiotics would you give the patient? And the majority of people gave somewhere around several days up to a week of antibiotics. Same question was posed, what if the patient had a positive urine culture prior to PCNL? How much antibiotics would you give them? And same scenario here, same response. The majority of people will give somewhere from 4 to 7 days of antibiotics prior to the PCNL. And I believe this was a polling question that we've thrown out to you, so we would love to hear your response to this particular scenario. But the point being is that there's a wide variance in how we administer antibiotics and what we think is indicated. And that variance is contributing somewhat to the problem that we have here with microbial resistance. This is data from the CDC showing that 23,000 deaths per year are associated with antimicrobial resistance. We have healthy bugs out there that Dirk has talked about, but what we do by indiscriminately giving antibiotics is that we wipe out the healthy bugs and then permit more deadly bugs to then grow unchecked. And in fact, some of these bacteria will then give their resistance to other bacteria, creating more problems. So it really is a vicious cycle. And this is leading to what many experts consider a perfect storm, where we're running out of available antibiotics in relation to the growing number of bacteria out there. In fact, the CDC on their website shows the problem here with the carbapenem-resistant Enterobacter. There were 600 deaths reported recently over a 1-year period. And for ESBL, there were 1,700 deaths annually reported. So this is not a trivial problem, and we're running out of antibiotics for the bugs that are out there. So UTIs after PCNL, we all know they're relatively common to have a fever. Maybe a third of our patients that undergo a PCNL will have a fever. What predicts a patient having a fever? Well, you can tell your patients the larger the stone, if there's any obstruction, how long UNI operate for, and if the patient subsequently grows a stone culture. These are all risk factors that predict the presence of a fever after a PCNL. Symptomatic urinary tract infections are a little less common in the single digits, and here are the risk factors. Fortunately, septic shock after PCNL is a relatively rare phenomenon, traditionally reported around 1%. The problem is, if a patient has septic shock, their mortality increases to about 40%. Again, not a trivial problem. And unfortunately, septic shock has now increased over time. This is a more recent report looking at the nationwide inpatient sample that shows that septic shock has doubled from 1.2 to 2.4%. And you can see again the single-digit UTI, just sepsis rate, but septic shock in itself has doubled. Well, what is sepsis? This term, if you look at the literature or if you read the media, it has a variance and a wide variety of vernacular associated with it. Sometimes you see the word sepsis, sometimes you see the word septic shock, sepsis syndrome, SIRS with infection, septicemia. There are many, many terms out there, and it's kind of confusing, truthfully. So most recently, a definition was proposed by here in the JAMA 2016 by experts, and they define sepsis under this as a life-threatening organ dysfunction caused by a dysregulated host response to infection. That is to say that if someone is exposed to an infection, the body reacts, but in sepsis, the body reacts in an abnormal way or overcompensates to the point that it starts not only killing the bacteria, but then attacking the host. And this is what we know to be. And to this point, recently, many experts wanted to find what is a better predictor for septic shock. And recently, this was proposed, the Q-SOFA, which is it is a bedside test that we can use that doesn't require any laboratory tests. So its utility in a practical sense is very high. So you only need your clinical acumen to predict the potential for sepsis. And what they found is that if you had 2 or more of these, the positive predictive and the sensitivity and specificity of the Q-SOFA actually outperformed using the SIRS criteria. SIRS, as you know, is tachycardia, hypotension, tachypnea, fever, leukocytosis. And if you have 2 or more of those, traditionally the SIRS criteria was used to predict septic shock. However, more recently, the Q-SOFA is now being proposed because you don't need laboratory tests. You can be at the bedside if the patient has a change in mental status, they're tachypnic, or they have hypotension. If 2 or more of these, this test actually outperforms using the SIRS criteria. And the mortality associated with someone who has this in a setting of infection is about 10%. And furthermore, should they then have hypotension requiring a vasopressor, or you get the blood test back for lactate being elevated, now the mortality is increased to 40%. So Q-SOFA is something that you and I can use at the bedside. And to this point, Brian Eisner and many of us in the EDGE consortium and outside of the consortium want to look at how does Q-SOFA function with PCNL surgery. And they replicated what was found in the other study in JAMA, that Q-SOFA outperforms SIRS for PCNL. The sensitivity and, more importantly, specificity was much higher. The sensitivity is Q-SOFA and SIRS is similar. It's at 100%. The problem is, if it's positive in SIRS, more often than not, it's an overcall, right? There's too many false positives. But if you use Q-SOFA, there's not an overcall. There's a very few false positives. So the chance of the patient truly going on to have septic shock is very high. So again, Q-SOFA is superior to SIRS, and this paper recommends using Q-SOFA as a bedside test for all the reasons I just discussed. A little bit about endotoxins. How often do we do a urine culture or a blood culture in the setting of septic shock and nothing grows out? Well, that's because you don't need to have bacteria per se to have a raging infection or sepsis. It's actually the presence of endotoxins themselves that actually can lead to these infectious complications. Now, more often, if you have an infected stone, you're going to have endotoxins, but you don't need an infected stone per se to have endotoxins. In fact, the presence of endotoxins do not correlate with urine cultures. So the point being that And endotoxins may cause SIRS in the absence of bacteremia or positive urine cultures. So how do we prevent infectious complications? The first question is, well, how long do we, once you do a PCNL, how long do you give antibiotics for after the PCNL? So you've done a PERC and you give a single dose of antibiotics at the time of surgery. How long after that do you give 1 day, 2 days? This question was answered by multiple studies looking at this, and they concluded that a single dose of peri-op antibiotics is sufficient. Now, this is for your index patient. Obviously, if the patient's getting septic, having a fever, or there's comorbidities like immunocompromised patient, you might want to consider. But for your index PCNL that goes well with no complications, a single dose of antibiotics is sufficient. You don't need to give antibiotics till the time of nephroscopy tube or stent removal. It's unnecessary. Goes back to my point of we're trying to be more judicious, and the data supports being more judicious in this sense. How about before a PERC? I had showed you the survey from Duke, which demonstrated a wide variance in the use of antibiotics prior to a PERC. Well, how long do you give antibiotics before a PERC? This question was answered by Mary Pam, and they conclude actually that a week of antibiotics before the surgery appears to reduce the risk of septic shock significantly by 66%. They gave a week of Cipro before their PERCs. Same question was then asked to or answered by the BAG study. This is a landmark study too that demonstrated a week of macrobid in a similar way also significantly reduced the chance of SIRS. The problem is both of these studies, although they are highly quoted, there are some limitations to them that made them the validity somewhat questionable. These are some of the things that I brought up and looked at. They're single institution. They didn't follow the common consort statement, which should be utilized for all randomized controlled trials. They also didn't include many morbid patients. They had a very homogeneous and clean recruiting. So the generalizability of some of these studies is a little bit in question. So to that end, the question is 7 days sufficient? And so we wanted to answer this question with the EDGE Consortium. We performed a randomized controlled trial with multiple institutions, all with negative pre-op urine cultures. We included any stone size. I will say we did exclude stents, PERC tubes, or catheters. And we gave them a week of antibiotics in one cohort, and the other cohort was randomized to just a single peri-op dose of antibiotics. And what did we find? We found basically that there was no benefit to giving a week of antibiotics. In contradistinction to the Mary Pam and BAG study, we demonstrated that a single dose of antibiotics, and just with a negative pre-op urine culture, that's all you need. You don't need a week of antibiotics prior to a PCNL to lower the risk of sepsis. Now, the one caveat to this is in a low-risk cohort, and what I mean by low risk is all the patients had a negative pre-op urine culture. Well, then you may be asking yourself, what do I do if a patient has a positive pre-op urine culture? Well, we actually then went on to perform what I call the PCNL2 trial. We then replicated the study, but all our subjects now had a positive pre-op urine culture. In fact, we included any patient who had a stent or nephroscopy tube as well. You didn't have to, but if you did, you could be enrolled. And after 133 patients, we also again demonstrated that 7 days versus 2 days of antibiotics, there was no difference. That giving 7 days of antibiotics appeared to have no additional benefit to reducing your chance of SIRS. So we concluded that 2 days of preoperative antibiotics, even in this high-risk population, is sufficient to reduce the risk of SIRS. Quick comment on mini PERCs. A lot of people talk about mini PERCs increasing the risk of sepsis since the sheath is smaller. Maybe there's higher intrarenal pressures. Two recent meta-analyses both refute this claim, and they demonstrated that there's no increased risk of sepsis with a mini PERC. How about ureteroscopy? Well, ureteroscopy has a risk of sepsis, anywhere from 2 to 4%. And in fact, if the intrarenal pressure is greater than 30 millimeters of mercury, there's going to be some pilovenous backflow. So therefore, a sustained pressure irrigant of greater than 30 millimeters significantly increases your risk of sepsis. So that's kind of the number that a lot of people talk about. Now, unfortunately, we can't really measure that pressure, but there is one thing you can do if you're concerned. This study put out by the Crows showed that using an access sheath significantly decreased the risk of sepsis by 50%. So I'm not saying you have to use an access sheath, but merely making the comment that if there's a concern about sepsis in a patient, using an access sheath will significantly decrease the risk of sepsis. These are some of the risk factors that are associated with SIRS and uteroscopy, length of surgery, and at a personal level, I feel like this is one of the most important things. I like to limit all of my surgeries to less than 2 hours. It's an arbitrary time limit, but it is a time limit that creates like a hard stop in my mind that reminds me, you know what? It's better to come back at a later time and perform a staged ureteroscopy than to place the patient at risk for surgery. So all my patients up front know, look, there is a chance we may need to do a secondary procedure. So that expectation is laid up front. So if it happens, they're not disappointed. Use the minimal amount of flow rate to visualize things. Consider an access sheath. This study by Zhang in 2050 suggested a larger access sheath. I think the point is, if you're concerned, use an access sheath. So in conclusion, my take-home points are: consider using the Q sofa at the bedside to predict septic shock. It's more practical. Number two, if you're doing your standard perk, a single dose of antibiotics is all you need for a standard case. If the patient's high risk, like they have a nephrostomy tube, stent, or they have a positive urine culture, our data suggests that 48 hours of antibiotics is sufficient. Another thing is, for all endoscopic cases, set some type of arbitrary operative time to create a hard stop to your case. Use the minimum amount of flow so you can see, particularly with uteroscopy. Many perks do not increase your risk of sepsis, and consider using access sheaths. Thank you so much. Okay, so we're going to go on to our next speaker, who is Dr. Ojesh Shah. Dr. Shah hails from Colombia, and he'll be talking about complications of PCNL. And I'm going to be throwing out the poll, so feel free to answer the poll if you would. Q&A, if you have any questions, myself or my other panelists will answer them while we're talking. Thank you so much. Go ahead, Ojesh.
Thanks, Roger. Okay, so we're going to move on from infectious issues, and that's part of PCNL, but I'm going to leave that up to Roger's talk since he covered that extremely well in great detail. Complications of PCNL, which is something that we should all be prepared for. Whoops. Let me close the poll for me. These are my disclosures. All right, so for complications, prevention is obviously the best management. You need to adhere to proper protocol, and patient selection will obviously prevent complications in the majority of cases and remain within your comfort level. We're going to say there's lots of potential complications that can occur when you start performing PCNL, both mini, macro, any type of percutaneous access will lead to potential issues. I'm going to stay with the left side of the screen, which is the surgical complications, which include bleeding, collecting system injuries, thoracic, colonic, and other visceral injuries. And there's a whole plethora of other types of complications that can occur. The medical sides, which are the infection and sepsis, and then also fluid overload, positioning-related injuries, hypothermia, air embolism, DVT, pulmonary emboli, and loss of renal function. So we'll stay with the surgical side. So how do we prevent hemorrhage? So everyone probably that does PCNL should know a great detail of these types of things, but maintaining adequate knowledge and remembering all of these potential issues that you'll encounter during surgery is really critical. So proper patient position and preparation, proper calyceal puncture. This is a little bit controversial more recently. We always assume that if you do an non-infundibular puncture, a papillary puncture, that you would probably have the least risk of hemorrhage by avoiding the interlobar arteries and interlobar vessels. This has come into a little bit of controversy with Dr. Liatzikos recently putting in a non-papillary puncture just has the same risk as a papillary puncture in hemorrhage. But the gold standard thinking process has always been in the past that a papillary puncture has the least amount of hemorrhage risk. Proper dilation versus minimal dilation. Your position of your working sheath is very important. Avoid rigid instrument, torquing your rigid instruments, and switch over to flexible instruments whenever necessary to prevent bleeding and tearing infundibuli. And then is there some role for bioglues and fibrin plugs for prevention of hemorrhage? There's limited evidence to show significant benefit for this, though there are quite a few users of these in practice. The contemporary reported transfusion rates have been somewhere between 1 to 34%, 1 to 3 to 4%. Let's not go to 34%. That's in old literature. But the most recent studies have shown about a 1 to 2% transfusion rate. This is based on surgical technique, surgeon experience, pre-op anemia, advanced patient age, increased stone burden, and multiple tracts. These have all been shown to have increased risk of transfusion. Intraoperative complications can occur, such as infundibular tears or pelvic wall tears, which can increase bleeding risk. And tract size has been shown to be relevant. When you decrease tract size, mini-perk's one of the biggest advantages is that the transfusion rate and bleeding risk is decreased. So by decreasing our tract size, even decreasing from when I was used 30 French sheaths down to 24 French sheaths, I've noticed not a transfusion decrease, but a decrease in blood loss, and my postoperative hemoglobins tend to not budge very much when switching to 24 French for the primary amount of my PCNLs. So if you have high volume intraop bleeding, you need to figure out whether this is arterial and venous. Part of it can be determined just by looking at the color of the blood. Part of it can be determined based on the flow of the blood and how rapidly bleeding is encountered. It could be working sheath position. So the first thing you should check is your working sheath and make sure that's appropriately positioned within the collecting system. If you encounter high volume intraop bleeding, one of the first things you can do after placing a plug over the sheath is reinflate your dilating balloon, placing it back over the wire and seeing if that will tamponade the bleeding. And you can usually leave this inflated for several minutes to allow for the bleeding to tamponade. You can insert a large nephrostomy tube and then clamp it in order to see if the bleeding slows down or not. You can use a tamponade catheter. There's one made by Cook, that K-tamponade catheter that you can use to try and slow down bleeding, though I've never had to use one of these at this point in time in my career. There are people that have used it with great success. And then the big decision of whether you need to go to exploration or angiography. So again, these are the first few steps that you can do. You can put in a nephrostomy tube and clamp it. You could put in a tamponade catheter, or that you could proceed with angioembolization or open exploration. This is a post-op hemorrhage where the patient developed a perinephric hematoma following the procedure. These are typically managed very conservatively, and with a little bit of time, the hematoma will resolve. And typically, the only thing that would be required for this, if the hemoglobin dropped low enough, is transfusion. This does not typically require any sort of intervention. So what happened here? These are a couple of papers that came out of the Chinese literature that has showed where a nephrostomy tube actually went through the tract and was placed all the way into the venous system. So you can see it traversing into the renal vein. They actually wrote an interesting article as far as how do you manage these types of very complicated injuries. So if their recommendations, and this again is based on limited literature out there, but if you have a renal vein adjacent to the renal sinus, if you have a tube that's in the renal vein adjacent to the renal sinus, one step is remove the tube about 7 days later and do this under monitoring, either under fluoroscopy in the operating room or do it under CT or ultrasound guidance to make sure that you don't run into a major issue when you remove the tube. I would say under fluoroscopy is probably your best bet in an interventional radiology suite or in the OR in case there's any sort of problem with this type of injury. And if you have a renal vein, IVC, or atrium tube, and these have been shown in their study as well, they do a two-step process for removing the tube. Immediately, they reposition their tube into the renal vein just proximal to the sinus, and they typically would do this with some sort of imaging guidance. And then the second step is removing the tube about 7 days later, again under some sort of monitoring method. Pseudoaneurysms can occur as well. These are typically in the postoperative period, and you can see these are two images of a pseudoaneurysm that occurred postoperatively. And then this is after they've been coiled, or sometimes they'll place glue or coils into these areas in order to stop the bleeding, as you can see on these images here. So no longer the extravasation noted in these sites at the aneurysm sites. This is an AV fistula that we picked up in our office with ultrasound, and it showed the immediate AV arterial venous flow, artery vein. And then this was the arteriogram that was done that showed these two bleeding points inside of the kidney. These were both taken to interventional radiology and embolized and led to no further extravasation or bleeding from those sites. And that's multiple tract access. So delayed post-op hemorrhage can occur. Most can be managed conservatively. 1% will require invasive treatments and typically occurs about 1 to 3 weeks post-operatively with the laceration of a segmental artery, AV malformation, pseudoaneurysm, or AV fistula. And the treatment of choice is angioembolization. And there's a reported rate of approximately 0.8 to 1.3% in the reported literature that's out there. And the primary goal is to stabilize these patients hemodynamically. Collecting system injury. This was a picture sent over to me from my buddy Brian Eisner. He actually did this case and had a renal pelvis perforation that occurred right at the beginning of his surgery. And you can see the extravasation noted immediately after intraoperatively around the kidney. He placed a nephrostomy tube and 36 hours performed a nephrostogram, and you can see how the pelvis has healed almost immediately. So that type of injury has probably sealed off already. My personal preference on this would probably be to go in about 5 to 7 days later to allow that area to completely heal if we needed to go back, just to prevent any sort of re-injuring of that tract to give the mucosa some time to heal. That typically will occur around day 5 to 7. If there was no residual stone and this was an image at the end of the procedure, then basically once the nephrostogram shows that there's no evidence of extravasation, I would leave this tube in a little bit longer and take it out about day 5 to 7 as well when you had an injury that caused this much extravasation. So collecting system injuries, you can see them with endoscopic findings. Retroperitoneal fat can be seen, perirenal or periureteral structures. The clinical findings are typically abdominal distension, flank distension, or a discrepancy in irrigant fluid. This is very difficult to manage because irrigant fluid is very difficult to keep track of, even with the best tracking devices, just because there's so much loss of fluid that occurs sometimes on the floors and other areas during the surgery. The treatment typically, if you have a collecting system injury, will be a nephrostomy tube and urinoma drain if needed, if there's extensive injury, and then reconstructive surgery if needed. And that would be extremely rare. All right, this is an image of a patient that we did a PCNL on, that we did not do a PCNL on, because we see these images preoperatively. So imaging preoperatively is extremely critical, and we always recommend some sort of axial-based imaging for these types of studies. And as you can see here, there's a retrorenal colon, and it extends all the way from up here near the splenic area, the splenic flexure, all the way down, so that you would actually have almost no clear access into this kidney. There's another paper put out from Iran where they did a PCNL for these stones in the ureter, and the patient had a preoperative stent, and they did a postoperative KUB. You can see that the tubes are not ideally placed in the sense that their stent is sort of malpositioned. This is one from their paper, but it did show on their post-op KUB to make sure that they were stone-free, that they actually have contrast throughout their bowel, consistent with a bowel injury during their procedure. So colon injuries occur in less than 1% of cases. This is a case that was during my fellowship years ago where the nephrostomy tube went right through the intestines. Risk factors, retrorenal colons occur in about 0.6% of patients. So that's why we CT scan or even MR image our patients preoperatively. If you have an MRI already on that patient, no need to proceed with a second imaging study if you know that they have a large stone. You can just look at the MRI to see where the bowel lies in relationship to the kidney. It happens in patients with hypermobile kidneys, lateral access, renal ectopia or horseshoe kidneys, neurological impairment, institutional bowel, and quite often in young, thin men. Colon injuries. So this is a old picture of intraop diarrhea or hematochezia can occur as a sign and symptom for this. You can see fecaluria or feculent material through or around a nephrostomy tube. Sepsis and significant risk, and the patient may present with simple signs such as abdominal pain or even leukopenia or leukocytosis. The diagnosis would typically be with a post-op CT scan, but you can also see it on a nephrostogram intraoperatively or postoperatively, where you see bowel loops on the nephrostogram. So the management of this is a little bit controversial, but the gold standard management is typically if you have a transperitoneal injury with any signs of sepsis or peritonitis, this should move on to an exploratory laparotomy. If you have a retroperitoneal injury, these can typically be managed conservatively. Typical management is with a colon tube. You can devance the tube and then perform a cologram 7 to 10 days later to show that the bowel mucosa or the bowel lining and the kidney lining have been separated. And then at that same time, place an internal double pigtail stent as soon as you notice that there's a colon injury, and a Foley catheter to maximize drainage. The patient should be placed on a broad spectrum antibiotic course, and they should be made NPO and then slowly advanced to a low residue diet to prevent any sort of renal fistula. Thoracic injuries, this is in 0.3 to 15% of cases in the reported literature. I would say it's quite low overall, but increases as you get to supracostal access. You can either get hydrothorax from irrigation fluid, you can get hemothorax, which can happen from bleeding from the kidney or an injury to an intercostal vessel. There's a risk of pneumothorax, however, that's quite small, and you can develop a renal pleural fistula from these. There's an increased risk with supracostal and upper pole access. Typically, when you get above the 11th rib and the 10th rib on access, your rates can increase to 5 to 10% or greater for a thoracic injury. These can develop into an empyema if there's if the urine or stone are infected. So specifically, if you are concerned about a struvite or infected stone, the drainage of this type of nephros at the end of these procedures would typically be with a large bore thoracostomy tube rather than a smaller pigtail catheter. The diagnosis can be made with intraoperative fluoroscopy. We typically perform a fluoroscopic view of the chest any time when we do a supracostal access to see if there's any signs of a fluid within the lungs. Look for the lung linings or the pleural linings. Also look for a sharp diaphragm border. If this is questionable, this can also always be reevaluated with a chest X-ray or CT scan in the recovery room.
Oh, just a 5-minute warning, please.
Yeah, no problem. Almost done. Thoracic injury again. The treatment, you can aspirate the hydrothorax during hyperventilation. The placement of a thoracostomy tube, either a pigtail or large bore chest tube, especially if infection is suspected, as I mentioned. If there's a small potentially fluid collection or a small pneumothorax that occurs and it's reasonable and the patient is asymptomatic, you can potentially observe the patient. And if you did end up having a empyema or anything of that sort, a video-assisted thoracoscopic surgery may be necessary to clear that empyema. Hepatic injury, again, fairly rare. It's usually diagnosed on post-op CT scan imaging and can be potentially avoided by knowing your anatomy preoperatively. Most hepatic injuries can be managed conservatively. This is a transhepatic PCNL that is that occurred, and these have even been performed electively when necessary, just based on no other approach into the kidney. And these have been reported to be fairly safe in general. What happened here, this is a picture of Ben had sent me, one of his spleen injuries at one point, just to show like how it can occur. But these are more disastrous than potentially liver injuries. These patients can develop hemodynamic instability with massive bleeding, potentially, and surgical exploration and splenectomy may be required. If these patients are stable with minor bleeding, typically the recommendation is prolonged immobilization, prolonged nephrostomy tube drainage to allow this tract to mature, and then either have these tubes removed via interventional radiology or with vascular on standby, just in case this starts to bleed profusely, and a tube would be replaced and potentially require exploration. How can you prevent this again? CT scan or MR imaging will allow you to know your surrounding structures. This side would be potentially experience a retrorenal colon in the lower pole, but in the upper pole, there's no real issue, or upper to mid pole access points, there would be no real issue. So that would be your point of access potentially. If there are issues with bowel overlying or causing retrorenal colon or overlying your kidney, especially in pelvic kidneys or transplant kidneys, ultrasound or CT guidance can be used to obtain percutaneous access. Post-op CT imaging should be considered for early diagnosis in complex cases. And again, fluoroscopy would be useful. So for the major complications that occur from these types of surgeries, always be prepared that complications can occur. Again, prevention is the best management. Cross-sectional imaging, as recommended by most guideline statements, including the AUA, Endourology Society guidelines, recommend cross-sectional imaging prior to any sort of percutaneous intervention such as this. Have a safety wire for the majority of cases in case you lose access in your case, you run into major bleeding, you can hopefully control it. And always visualize the action of your instruments and energy sources to prevent bleeding, tearing of the infundibuli, and collecting system injuries if at all possible. When unsure or encountering difficulty during a procedure, you can use fluoroscopy for orientation and assessment of the situation. If you're still unsure, you're encountering difficulty, always consider placing a nephrostomy tube and performing a second stage procedure. Thank you.
Thanks, Otis. I'm actually going to take a question here from the audience and love to get your input on it. Hold on, it just moved on here. So the question is from Dr. Patel in the audience. Says, thoughts on the follow-up of a thoracic injury? If someone had a hydrothorax and his chest tube was placed, any advice on the follow-up or timing of the tube removal? And also, how about concurrent management of a nephrostomy to prevent nephropleural fistula?
So that is a great question. Typically, early on in my career, I would manage the chest tubes myself. And later on, it became more evident that if we ever got thoracic involved, they would take over the management of the nephrostomy tube. I typically will take out my nephrostomy tube if I do place one in one of those cases prior to removing my thoracic tube or chest tube, just to in case there's any leakage that would occur, that the thoracic tube would be able to manage it and drain it. And then when that output starts to decrease and you place the chest tube on water seal, if there's no more drainage and imaging shows that there's not much more fluid left behind, we usually remove it within a couple of days. So that's our general management of them. But again, these are fairly rare. I think I've encountered 2 or 3 in my entire career, and they've healed very well. I saw a couple in my fellowship, fairly infected stones that did develop empyemas that required VATS procedures, but I've never seen that since then.
Great.
What about you, Roger? Any difference?
No. I think you make a great point. I think at a certain point, it's always great to kind of, for not only clinical, but even for risk management purposes, I think to, bring more people on board and to, leverage expertise. I think it's always a wise decision.
Yeah, I think so too.
So running a little behind here, I'm going to let Dr. Seth Beaches, who's an assistant professor of urology here at UC San Diego, to talk about optimizing shockwave lithotripsy. Thank you, Seth.
All right, thank you, guys. Thanks very much for the opportunity to speak with you. I'm going to talk about shockwave lithotripsy. These are my disclosures. Shockwave lithotripsy used to be the most commonly used treatment for renal stones since the 1980s, owing to its non-invasive nature and low complication rate. In the last 10 years or so, ureteroscopy has really grown in popularity among younger trained urologists, both for the increased competence in performing surgery and also the higher stone-free rate. Nevertheless, shockwave remains a highly utilized procedure option and has some great benefits to the patients in terms of morbidity. And so for that reason, I think a discussion is warranted about how best to optimize technical parameters and selection of patients to increase the likelihood of success. So when is it useful? The AUA guidelines in 2016 recommend that shockwave lithotripsy can be an option for symptomatic patients who have a total stone burden in the kidney of less than 20 millimeters if it's not in the lower pole. If it's in the lower pole, then less than 10 millimeters is recommended. And this has to do with the success rate of the procedure and its relative comparison against other procedures like ureteroscopy or PC now, which we'll talk about later. It's an option for ureteral stones of any size, although it is important to note to the patient that while it has the least morbidity and the lowest complication rate, ureteroscopy does have a greater stone-free rate overall. And finally, for mid or distal ureteral stones, less than a centimeter, when patients decline ureteroscopy, the guidelines would recommend shockwave as the preferred approach. So how does shockwave work? The principle behind it is that an energy source rapidly deposits pulses of energy, which are faster than the speed of sound, into a fluid environment. And this generates what's called a shockwave. Shown here is the electrohydraulic shockwave generator, which is classically found in the HM3 and the first generation machines, where you can see a spark is being generated within a fluid container. Most modern machines that we use today are electromagnetic generators, whereby you have an electromagnetic coil that generates the energy pulses into a fluid collection, and it's focused through this focusing medium. The lithotripter relies on shockwave focusing to focus the energy into the focal target, which is called F2 in these pictures. And the successive shockwaves that result lead to direct shearing forces and fracture mechanisms, which ultimately fragment the stone. There's a variety of fracture mechanisms. We won't go into the physics of these today for the sake of time, but some of the highlights are that you generate what's called a spall fracture. And this is from the energy causes a tensile wave, which leads to the formation of micro cracks within the stone that eventually coalesce to form large fractures. There's also squeezing splitting, which has to do with the difference in the sound speed between the stone and the surrounding fluid, direct shearing forces, and ultimately formation of cavitation bubbles, which is free gas at the nucleation sites that are under stress. And these bubbles grow, fill with vapor, and grow in size, and then ultimately collapse violently, leading to high pressures, which cause the stones to break. There's a variety of factors that affect outcomes, and these can be both on the level of the patient and the stone and anatomic considerations, as well as the technical variables of the machine itself. And we'll try to touch on many of these. So first off, obviously the calculus itself. Stone size plays a significant role in predicting the success of the shockwave therapy. The data would support that as the stone increases in size, the likelihood of becoming stone-free decreases to the point where over 2 centimeters, the stone, you have a very low success rate. And right around 15 millimeters or less, you have about a 2-fold greater likelihood of its success than if the stone is larger than 15 millimeters. And for the lower pole, I think the original study by Lingman in the 1990s found, a meta-analysis found that for lower pole stones, if they're less than 1 centimeter, the success rate is in the 70%, but as soon as you climb above 1 to 2 centimeters, that success rate significantly drops. Now, skin to stone distance is also important, and this is a factor both of patient anatomy, also BMI plays a role here. There's been a variety of studies looking at what is the optimal distance, or is there a threshold? And depending on the study that you look at, it seems like somewhere in the 7 or 8 to 10 centimeter range. If the distance is greater than 9 or 10 centimeters, the success rate of the shockwave therapy decreases dramatically. So in general, I think a skin to stone distance of around 9 to 10 centimeters. If you're below that, you'll be able to perform shockwave. Finally, also the stone density. Hounsfield units clearly are an indicator that we use based on preoperative imaging to make an estimate of the density of the stone. And again, some different studies have looked at trying to segregate these into different groups by Hounsfield units, and somewhere in the 700 to 1,000 Hounsfield unit range seems to be a tipping point where stones over 1,000 Hounsfield units have a substantially lower likelihood of being successful. It's important to note these studies used a variable definition of stone free, anywhere up to 3 to 5 millimeter fragments. Finally, the composition of the stones plays a role. So hard durile stones like bruchite, cystine stones, or calcium oxalate monohydrate are going to be more challenging to fragment. And matrix stones, which tend to have organic matter or post-infectious debris, also don't fracture as well, just due to the nature of the shock waves hitting the physical limitations of the materials. So obviously, if we want to fracture the stones more successfully, targeting the stones plays a key role. Being able to define the stone, visualize it, and target it within the shockwave therapy. And to that degree, you can imagine the more the patient moves, the less likely or the more difficult it can be to target the stone. One of the selling points of shockwave therapy is that it's commonly performed without the need for general anesthesia. patients can have either local or a monitored anesthesia care. And this can be a nice selling point in terms of lowering morbidity of the procedure. But it's important to recognize that there are limitations if the patient tends to be more sensitive or moves, or if they don't have a good anesthesia on board or analgesia. If they move, then it may be more challenging to target the stone, and that may translate into a lower success rate. One study found the average respiratory stone motion was about 1.5 centimeters during the case, and that only about 60% of shockwaves were actually delivered to the stone based on patients moving. The use of general anesthesia in that case was superior, obviously, because you can control the respirations and really limit the mobility of the stone while you're targeting it with the shockwave. There are other techniques such as high-frequency jet ventilation and sophisticated tracking software that are being developed to try to better target these stones. I think the take-home point is, while some people prefer to use general anesthesia at all times, I think if you like to incorporate other options into your practice, then there are probably cases where you may consider general anesthesia, and that might be patients who are particularly anxious, or if you're planning a longer procedure such as a harder stone, or if you have multiple locations you're going to be targeting at once. Those might be times where you would favor a general anesthesia during your case. What about coupling? So the shockwave therapy really depends on the transmission of the energy from the lithotripter to the patient. And originally, the first generation used this nice water bath. The benefits were the energy was transmitted to the patient. Nowadays, we now use dry treatment heads requiring coupling mediums. And the goal of any of these coupling mediums is to really allow efficient energy transfer. And the challenge is that any pockets of air that end up in the gel matrix lead to a reduction in transmission of the energy. In fact, only 2% air can lead to 40% less fragmentation. You can see here illustrations showing techniques of applying the gel. And the key is to avoid hand application of the gel, because that can create more pockets of air and ultimately lead to less energy transmission. So the goal is to deliver a large volume of gel as a mound onto the lithotripter water cushion. Some of the newer machines as well also have video cameras that can magnify the picture of the gel to help seek out air bubbles and fix the problem before you begin. The focal zone of the shockwave lithotripter can improve stone breakage. Obviously, the larger the focal zone, the more able you are to contain the stone within it. And if we think of the acoustic output of a lithotripter as the amplitude and spatial distribution of the acoustic energy delivered into a volume, then if the stone is smaller than the focal zone, it's more likely to have a better fragmentation. Most lithotripters are around 6 to 10 millimeters for their focal zones. And so obviously a stone that's in that range or smaller has a higher chance of becoming fragmented quicker. One thing to note is that a narrow focal zone also decreases stone breakage, but it can cause more renal injury as well, because it's concentrating more energy into a tighter spot. What about pulse rate? So there's a variety of pulse rates, anywhere from 30 up to 120 or 150 shockwaves per minute. And we're always challenged to find that balance, that the faster the shock rate, the quicker the case. But it turns out there's a sweet spot where it may be less energy efficient and a less effective dose of energy if our shockwave rate is too fast. And several studies have looked at this and found, both in vitro and vivo, and some meta-analyses. It seems like 60 to 90 shockwaves per minute improves the success rate at the trade-off of not being too slow. I think some studies would favor 60 shockwaves per minute. And that's partly because the cavitation bubbles at the stone surface are more effective at breaking if they have a little bit more time to grow. And then also renal damage is reduced when you have a lower pulse rate, which we'll look at in a minute. And then there's the question of ramping up or pausing. And it turns out in a prospective study that looked at 45 patients where they either ramped up energy versus kept it at high energy from the beginning. The ramping up had a higher stone fracture efficiency, but also was less damaging to the kidney. And it turns out you can get hemorrhagic injury from these from the shockwave, and using a low voltage energy first and then increasing that energy to a higher level, or using a 3-minute pause, or using the two together, both have been shown to have less injury on the kidney. So it's important to know that I think the 3-minute pause, or the pause for the cause that we were taught in training, certainly is worth remembering. But you can also do a low voltage setting for 3 to 4 minutes without a pause, and then jump onto your higher energy setting. That has also been shown to be equivalent. And finally, the actual voltage you end up using, whether you're using a max setting of 4 or 8, is less important than the act of actually increasing the energy unique to whatever machine you're working on. This is just an illustration showing on the left a kidney that received 2,000 shocks at high voltage to the lower pole. You can see all the hemorrhagic injury. Interestingly, if they then shocked the upper pole after that, and it's almost as if the initial shock was a pre-treatment by passing a low energy to the upper pole indirectly, then by doing the formal treatment, the upper pole was protected. Likewise, on the right, you see starting with 500 shocks at a low voltage and then increasing to 2,000 shocks at a high voltage had significantly less injury to the kidney. Finally, in terms of passing the stone fragments once they've been created, alpha-1 antagonists have been shown to increase the success of shockwave therapy. Increased stone free rates as early as 2 weeks, all the way out to 12 weeks, depending on the study, with very high stone free rates. Also leading to lower complication rates, lower readmission rates, quicker expulsion of fragments, which also translates into reduced analgesic requirements. So in summary, a stone size less than 2 centimeters with a skin to stone distance less than 9 centimeters. Those are ideal candidates, or very favorable candidates, to consider shockwave therapy. Make sure you use a lower pulse rate, anywhere from 60 to 90 shockwaves per minute, to enhance your fragmentation and reduce renal injury. A pause and or ramping up of energy. Consider general anesthesia, especially in cases where you really want to maximize your success rate of the procedure. Consider alpha blockers. And I put up a summary here, just highlighting the things we talked about. Thank you guys very much, and stay safe.
Keep that slide up just for a second if people want to take a picture or just look at it. Thank you so much, Seth. So we're going to move on to our next talk with Dr. Matt Sorensen from the University of Washington, who will be talking about breakwave lithotripsy. This is our latest technology to have hit into urology that's incredibly exciting, and we appreciate him taking the time to come talk to us.
Yeah, thank you for the opportunity to present. I think that this work is an effort that goes back several years, and I'm going to share with you some of our latest findings and some of our latest efforts in treatment of stones using a new form of acoustic energy. I do have a disclosure that I have an equity interest and a scientific advisory board for Sonomotion, which is the commercialization effort that has the exclusive license to this technology that spun out of the University of Washington. Our long-term goal for more than a decade, in conjunction with some of our collaborators through a PO1 grant at Indianapolis, Caltech, Oxford, and others, has been to first started with some of the shockwave lithotripsy research that was highlighted in Seth's talk. But then over the last 10 to 15 years or so, we've transitioned to trying to make ultrasound have a more prominent role in the treatment of stones, including the improving efforts to detect stones to then be able to target them, to detach, break, and potentially expel the stones. And so this little diagram on the right is great here because it shows a stone that is causing dilation at the UPJ, and then we pushed it back with a technology called ultrasonic propulsion that I'm not going to talk very much about today. Then fragment the stone with burst wave lithotripsy, which is the primary focus of today's talk, and then potentially be able to push those small fragments out. And the hope is that this would be a sort of point of care, potentially in the clinic application, and we'd have one device that could do all these things. This is a comparison of the two. On the left is the University of Washington research ultrasound system. It is has a handheld probe that has an imager that runs through the center of it, and so the imaging is inline there. And then on the right is the very pretty commercial effort that is the sum, which we labeled the technology breakaway. They're very similar in their application. The imaging and therapy probes are coordinated together like this. There are some differences between the two in the approach that we've taken, but nonetheless, they're both handheld and they have an ultrasound imager that goes through the center. There's also a imaging and all the nuts and bolts and software and hardware that allow us to image and also to generate the propulsion and the break wave or burst wave energy there. And then on the right side, there's a control pedal, which has been the primary method that we've used to deliver these pulses with the commercial device. And for the UW system, there is a foot pedal, but often we use the click of the mouse. Actually, either one works fine. This is an example of a real-time fracturing of an 8 millimeter calm stone. The video length is about 1 minute, and it has not been sped up, but it will hop forward a couple times as you watch this. It's obviously an in vitro experiment, and we have a water gel or water and a gel that the stone sits within. And the total duration of this treatment is about 8 minutes. And so you can see we're at about 6 minutes here. You've got a bunch of small little fragments around the outside. And by about 8 minutes, we have the stone treated completely to fragments that are less than a millimeter. So how does this technology work? So a lot of the knowledge that we've gained about how shockwave works directly translates to burst wave. And essentially, rather than providing one really high pressure, high power pulse every second or every half second or whatever your rate of treatment is going to be, instead we deliver much lower pressures, but they're delivered over and over again. And so the energy is still acoustic energy. It's just provided at around to a tenth of the peak positive and peak negative pressure. And so this is the sinusoidal delivery of ultrasound. And what that does is it results in a different fragmentation pattern. And so you can see, starting with this diagram or this picture if you follow the upper pathway, shockwave lithotripsy tends to work by division. And so you get your stone that then half, and then those pieces break in half, and then those pieces break in half. And hopefully, if everything goes well, then the stone breaks into tiny little pieces that we potentially could use ultrasonic propulsion to push out of the kidney if they remain behind. Burst wave lithotripsy works by creating a surface fracture pattern that creates these tiny little fractures on the outside that then fall off, leaving a center piece that then generates cracks of its own and gets smaller and smaller. And so one of the benefits of this technology is that, if you have a shockwave procedure where you only march part way along that pathway, then you could end up with meaningful sized pieces that are left over. And whereas with burst wave lithotripsy, if you have anything left over, it tends to be whatever the dominant stone is in the center, and all the pieces that get created are tiny fragments. So we tend to think about this almost like when you do your readeroscopy, the difference between breaking the stone and dusting the stone, because the little pieces that chip off the outside of a BWL therapy are more consistent. And so this is a little video of a Bego stone, which is a fake calcium oxalate type stone, and the ultrasound is being applied from the left, and you can see that you're slowly whittling away at the outer surface of the stone. And if you stop the treatment part way, then on the right side you get this fine dust and have whatever's left over remaining in that top left corner there. So how does this work? So one of the things that we learned is that the frequency that the pulses are delivered at has a large influence over what the size of the fragments are. And so these fragments that chip off the outside are predictable. And that's one of the big advantages of this technology over shockwave lithotripsy. So on the left here, you have these 170 kilohertz, 340 kilohertz, and 800 kilohertz. And they set up these standing waves, these standing points of tension in the surface of the stone that are either far apartly spaced, lower frequency, or very tightly spaced together for the higher frequency. And because we're delivering multiple cycles, you get these pressures that get good, and then can result in surface cracks that also display the same difference. So with the 170, you get these cracks that are relatively widely spaced apart, and that you get are larger. Whereas if you go to the other end of the spectrum, the space in between these cracks are tiny, and you get really, really fine dust. But there's also a trade-off in the treatment time, and so the 800 kilohertz takes much longer to treat completely, even though it's a bit more thorough. And so with this in mind, we've selected a sweet spot that's about 340 kilohertz that results in that are less than a millimeter. And that way, if a couple of them get stuck together and they don't separate, then you'd still end up with pieces small enough that they wouldn't cause any or shouldn't symptoms when they clear. The other thing that we've determined is that we can use ultrasound to monitor for cavitation and injury. So this is a pig study. You can see this echogenicity that builds right in the center there. This is a super therapeutic study, and so we're well above treatment levels, and we can monitor for this echogenicity. And there's a little bit of echogenicity around the stone is okay, sort of like shockwave lithotripsy, but that echogenicity or cavitation, if it propagates into the tissues, can result in injury. And so this was after we provoked this cavitation in the tissue, allowed it to propagate for varying degrees of time, we could monitor for injury. And what we found was that that there was essentially 100% sensitivity. And so when there was no echogenicity, there was no injury. And if we allowed echogenicity to go on for longer periods of time at these super therapeutic levels, then we could generate some injury. And so this offers the opportunity for real-time feedback and a means by which to monitor with ultrasound for any injury that develops. We then have taken this to some pig studies, and this is an example of stones that were about 6 to 7 millimeters in size. They were treated they were implanted and then treated, and you can see that these 5 stones, this one's treated completely, this one's treated completely, this one has a dominant stone fragment that's left over, and that correlates with this stone fragment that's a little less than 5 millimeters, but all the other pieces are small. And you can see that for the majority of these calm stones, that the most of these fragments are around 1 millimeter in size, and certainly less than 2 millimeter in the large majority of cases. We also did some work recently. A college student did some work where we looked at combining burst wave lithotripsy with ultrasonic propulsion. And so ultrasonic propulsion is a non-invasive ultrasound pulse that we can use to push or move the stones. But what we found in this study was that if you use burst wave lithotripsy to crack the outer portion of the stone and then use propulsion, then it causes the little fragments that have generated on the outside to all fall off, exposing a new layer underneath. And so if you give 1 pulse per minute or 2 pulses per minute or 6 pulses a minute or pulse every second, we see greater and greater fragmentation than compared to if we just use burst wave lithotripsy by itself. Now, this has not been done in human studies, but it is an exciting opportunity to potentially make the technology more efficient. So what about in humans? So we currently have 3 studies that are approved to use this technology in humans. The first of these studies is through our PPG or the PO1 grant, and we're currently enrolling and treating patients at the University of Washington and at Indiana University. These studies are set up a little bit different between the 3 of them to try and gain information in different aspects of the treatment. But essentially for this trial, were patients that are going to ureteroscopy for whatever the indication is to treat their stone, that we use about 10 minutes of BWL while they're asleep in the OR. And then we tend to, we try not to introduce the ureteroscope. So we do it in parallel with getting access into the bladder and placing our wires and all those sorts of things. And then this allows us to go up and watch the remaining portion of the treatment and to truly assess the effectiveness. So the primary goal of this study is to try and optimize the effectiveness and to be able to see and watch how the stones break. There's also a NASA-funded study that's just taking place at UW where we're using this technology in patients that are emergently presenting to the emergency department or are symptomatic with a ureteral stone that we're trying to treat in clinic. And so these are primarily UPJ and UVJ stones. And we have been able to incorporate BWL into this treatment such that in addition to trying to push the stones either back into the knee or out, we can apply some burst wave lithotripsy to try and dislodge or even fragment the stones to facilitate either pushing the stone back or clearing the fragments. And then the last is a study that's being run by the commercial entity by Sonomu. This is a multi-center study, and so we have several sites of practice. This study totally would not be possible without Roger Sir at UCSD and Ben Chu at UBC and Jonathan Harper at UW, who are the PIs for the study. We've also recently included Chesapeake Urology in Maryland as a site, and there are a couple of additional sites that we're exploring as well. And this is a standalone procedure of about 30 minutes of treatment in the operating room. It is using what's expected to be and testing the future commercial platform and trying to mimic real world treatment parameters. And so one of the primary things that we're trying to do is assess the efficacy as if you were to use this like shockwave lithotripsy, and then also determine what the anesthetic requirements are going to be. And so before having used this in humans, it was not clear whether this was going to require no anesthesia, general anesthesia, or somewhere in between. In total, across the 3 studies, we've recruited 27 subjects. So this has been used in 27 people thus far. And we've treated about 30 stones. The candidates are very similar to shockwave lithotripsy. Basically, it's kidney and ureteral stones. There's no limitations on stone type. The guidelines in the study approval is for stone size fit within the AUA guidelines. But we're actually targeting stones that are a little bit smaller than that. They have to be visible on ultrasound. I guess that's one difference from a standard shockwave procedure. And they got to be nearer than 14 centimeters on their CT scan, which is a bit more than what we would normally do for shockwave. We're not currently doing this in any of these at-risk groups or any of these areas where otherwise be where shockwave lithotripsy would be contraindicated. So this is just an example. Only because the trials are ongoing, I can't share much in the way of our results thus far, but this is our first subject that we did. This was a patient that was in the UW study, and we have a report, or really it's a case series. There's 2 patients that's currently in review in the Journal of Urology, so I'm happy with you. This person had a ureteral stone that ultimately passed, but they had about a 7 millimeter left lower pole stone. We applied 9 minutes of burst wave lithotripsy with the ureteroscope, and we found small fragments when we got up into the kidney. And so by using some post-imaging processing and the size of the laser fiber as a comparison, the biggest fragments there is this dominant fragment here, which is a little under 2 millimeters. The others are 1.5 millimeters. You can see that there is just, this is, as we get up there is just a little bit of redness here. This is a little bit of blood, and these stones are hung up in. So there is just a little bit of surface sort of abrasion. The treatment of the stones, and the stones move when they're treated as well. But overall, things went really well. So in summary, this is a new form of non-invasive lithotripsy. It is outside the body. It's handheld. The fragment size is predictable and consistent, which is one of the advantages. It works in all stone types, though brushite stones, which are very dense and hard, have been particularly challenging. It provides the possibility of treatment in the clinic and real-time ultrasound monitoring for injury. The goal is that this will be treatment that could be performed in less than 30 minutes. And since there's targeting that's incorporated, our hope is that it will be easy to learn. I want to thank all of our collaborators. This is a number of the divisions and departments and institutions that participate in our PPG grant. And then there's also a small innovation grant that's in a phase 2B place that Sonomotion's been awarded to help try to bring this technology to market. Thank you.
Thank you so much, Matt. Fascinating work. I appreciate the update. So our next talk is with Dr. Vernon Pace. Vernon, are you there? Vernon had to go to the OR for an emergent case, and now he's having some technical difficulties. So I think for now what we'll do is we'll transition over to Dr. Sivalingam and his talk, which is a panel talk. And again, if you've got questions, please fire away. Sheree, if you want to go ahead and upload your talk, appreciate it. Thanks. And if the panelists could also introduce themselves, or Sheree, you could introduce them, that'd be great. Thanks.
Hi. How are you? I'm Sri Sivalingam. Thank you very much for having me on the panel today to moderate this discussion on complex ureteral stone management. I'm here from the Cleveland Clinic. And can you guys hear and see me okay?
Looks great, Sheree.
Fantastic. So I'll start off with my with some cases here. So the first case, I guess we only have you and Dr. Beaches on the panel right now. I guess Vernon is out for now. So first case is a 23-year-old male who is being seen for right flank pain and no prior urologic history, no significant past medical history, or no contributory past medical history. CT scan was obtained, which showed a 14 by 10 millimeter stone in the right kidney, and Hounsfield unit density was about 1,000 with 10 centimeter skin to stone distance. His lab work was relatively unremarkable, and patient ended up undergoing a right shockwave lithotripsy with a total of 2,500 shocks with a rate of 80 shocks per minute. He tolerated the procedure well, no immediate postoperative complications, but then presented to the emergency room 4 days later with flank pain and urinary retention. So they placed a Foley catheter, obtained a CT scan, and the only remarkable findings on lab work was that the creatinine had gone up to 1.61. So this is what the CT shows. Significant Steinstrasse spanning approximately 7.5 centimeters in the right ureter. There were also a number of renal stone fragments, which unfortunately I didn't capture on this image. But Dr. Beaches, what would be your initial management here in terms of first steps?
Yeah, so that's certainly an unfortunate complication that can come from shockwave, especially for a relatively medium-sized stone. With 7.5 centimeters of stone along the length of the ureter, clearly that's going to be an involved procedure to remove. I think initial management, either a stent or a nephrostomy tube to decompress. I think there is value here in both alleviating the patient's symptoms, also putting in decompression, because that may relax the ureter and actually allow some of these stone fragments to pass, which ahead of the time for the planned surgery, which could make removal of them later easier. I think with the stone burden, I would probably favor a nephrostomy tube placement if possible. And I say if possible, meaning if there's hydronephrosis there or if the radiologist is comfortable, because I think that in the initial setting, the chance of placing a stent is likely going to be difficult with all that stone and navigating. And also, there may be the opportunity later to do either a supine PCNL at the same time as ureteroscopy if needed to clear some of the renal stones.
That's great, Seth. So just like you said, initially the first thing we thought about is decompressing the system, and so a right nephrostomy tube was inserted. And like you said, you can consider either approach, going retrograde or antegrade, but in this case, we opted for PCNL actually. So the two options here are PCNL and ureteroscopy. Roger, any thoughts on how you would approach this in terms of retrograde versus antegrade?
So I like the option that you put in a nephrostomy tube for two reasons. One, it's a more efficient way to decompress the system. I think it's a more guaranteed way. Number two, it gives you the opportunity to consider an antegrade approach, both of which Seth mentioned. The only other thing that I would add is I would probably add an alpha blocker immediately for multiple reasons. Number one, it potentially will help with discomfort. Number two, it may facilitate passage of fragments. Number three, after whatever treatment you do, it will also facilitate passage of treatment of stone fragments. But as far as the technique goes, we've adopted a supine approach. And again, here's where a supine really shows its benefit, because you can go from above and below very easily. Not that you couldn't do that in prone, but in a supine, it really facilitates the endoscopic approach. I would probably start from below and do as much as I could, at which point, assuming the operative time didn't exceed a certain cutoff point, for me it's 2 hours, I would then have consented the patient for an antegrade approach to try to finish it up. I think most important for me is to tell the patient up front, this is not a one-step procedure. This is a staged procedure that may take 2 or 3 times. So I like to undersell it and over-deliver it, and that's how you keep yourself out of trouble.
Absolutely. Thanks, Roger. Vernon, just a quick question for you. Would you think there's any value in putting in an antegrade nephroureteral stent at the time of initial drainage?
It may ease the course if you are planning a retrograde approach. But shy of that, I don't know that I'd milk much additional benefit out of it.
Gotcha. So he ultimately underwent a right PCNL with a standard tract dilated to 30 French. Did pretty well. We ended up leaving a ureteral stent afterwards, and the surgical time was 95 minutes and pretty minimal blood loss. So this is a stone analysis and postoperative imaging. And just a couple of follow-up questions. I know that A lot of you guys do mini PCNLs, and is there any value in doing a mini PCNL in this patient with the renal stone burden of about 1 centimeter and the rest of the ureteral stones, as you saw? And this is open to anyone in the panel.
I think for this amount of stone burden, I probably would shy away and lean more towards a standard PCNL, either a 24 French or a 30 French. I think for several reasons. I think depending on the access, if you can get an antegrade ureteroscopy and potentially basket extract a lot of those stone fragments, I think having a larger sheath enables faster extraction. So I think that's a nice advantage. And if you potentially have a mid pole or an upper pole access, you may be able to have a nice angulation down the ureter to facilitate extraction through a larger sheath.
Yeah, I think it's more of the angle really as opposed to the size of the sheath. Where you get your access is going to be really important. If you want to get down the ureter, a mid or an upper pole facilitates that angle much more than a lower pole. You may get away with a lower pole, but you may also cut yourself short by getting a lower pole access, and then you can't get that angle. So it's not so much the sheath size; it's the site of the access. I will make one caveat that there is a size of the sheath at which you now risk damaging your scope. So a smaller sheath, somewhere around 17 French or so, you're really kind of putting your ureteroscope at risk as you pass it back and forth. In that scenario, you might want to consider a single-use scope. That way, you're not worried about capital loss.
Right, Roger. And that's an excellent point with using a mini PCNL sheath, especially as most of them are metal. This could actually cause a lot of trauma to your scope cladding. So great point. So we'll move on to the next case. A 75-year-old male who was seen for left flank pain, presenting with nausea, vomiting in the ED, has a history of intermediate risk prostate cancer. He underwent radiation therapy back in 2018. Otherwise, no other contributory history. He's never had kidney stones in the past. His lab work was relatively unremarkable, except for a previous ultrasound that showed a 155-gram prostate. This is the CT scan that was obtained at this presentation, showing a roughly 1.5 centimeter stone at the left UVJ. So, Dr. Pei, what would be your initial management here now? And this patient is presenting with nausea, vomiting, so a little bit more symptomatic than the last one.
So this patient has a good sized stone that looks unlikely to alleviate itself quickly enough. So I would be considering at least a stent to address his symptoms, and additionally to hopefully to assist with moving forward and getting rid of the stone ultimately. That giant prostate, plus or minus any radiation changes in the distal ureter, may make immediate ureteroscopy more difficult. This, as a matter of fact, is what made me late. Was a gentleman with a very similar situation that was a very challenging stent placement.
Gotcha. So, and so your view would be ultimately to proceed with a ureteroscopy. Ultimately, if you were able to get that stent in.
Yeah, it looks like a stone that I think is very amenable to ureteroscopy, and obviously less morbid ultimately. So that would be my preference.
Right. And that's totally fine. In this case, we decided to go for a nephrostomy tube placement just for the concerns that you mentioned, rightfully so. Large prostate, impacted stone, prior radiation changes. So all things considered, we thought this would be an ideal candidate just to have an immediate nephrostomy tube placed. And subsequently, we followed through with an antegrade ureteroscopy using a balloon dilator, a ureteral balloon dilator, and placement of a 1315 ureteral access sheath, and treated the stone in an antegrade fashion. So, I think if the concern was that sometimes you could run into trouble getting a stent in retrograde with an impacted stone, and And for that reason, as long as IR was available, we proceeded with a nephrostomy too. Seth, any thoughts on how you would approach this antegrade? Do you use a balloon dilator, or would you try to use coaxial dilators? And would you use a ureteral axis sheath or typical PCNL sheath?
Yeah, it's a great question. I actually think this is a great example of what you can do from an antegrade ureteroscopy in a minimally invasive fashion. So, effectively reducing the known risks of PCNL. So using a smaller tract size. He's had a nephrostomy tube placed already, which is presumably anywhere from 8 to 12 French. So I think I typically use a ureteral dilating balloon up to either 12 or 14, sometimes 16 French, and then just pass a ureteral axis sheath through that. I think if you run into trouble, you could use the serial coaxial sheaths. There is advantage, I think, to leaving the nephrostomy tube for a few days before doing the procedure. That lets the tract mature a little and also lets the patient decompress. And then I agree, I think at the end of the case, one other thing to consider is when you leave a stent, in an antegrade fashion, I'll often leave the string on the stent and externalize it through the flank. That way, you can remove it in 3 to 5 days' time by pulling it out the flank, and you save the patient having to do a cystoscopy, which can be a source of angst, and also in this patient with a risk of hematuria. So you can avoid that as well.
Thanks, Seth. And that's a good point with the tether left through the flank incision. My only concern with that, and I'm not sure if anyone has any other comments, is that sometimes if patients are a bit delayed getting to us and they don't want to pull it out themselves, you can get that tether sometimes caught within some epithelialization and makes it a bit difficult to remove. And I've run into that problem once before in clinic. So just a thought. Roger, any thoughts on a stone like this? When you go antegrade, do you think about laser settings? Do you think about dusting or fragmenting and extracting the stone through your axis sheath, or do you want to just dust it off and push it into the bladder? Any thoughts on that?
Yeah, I think this is a great opportunity to try dusting. I think dusting in this scenario really mitigates the chances for injury as you're extracting stones, the length of the ureter, losing stones as you're pulling them out. So I think a more efficient way is to simply attempt to dust and long pulse, or if you have the Moses technology, those are the settings that I would attempt to use. And then, like you said, just kind of pulverize it and then kick it out into the bladder. Though, one technique they're not mutually exclusive. Oftentimes I find myself starting dusting, and then if I have to basket a couple, I'll do that. But to your point, I think dusting overall is a more efficient way to deal with this type of stone.
Perfect. Do we have time for one more case?
Well, I'll be honest with you, we're a little bit up against the clock here. I'm trying to keep us on. So if it's okay with you, I'd like to transition to Vernon's talk.
No problem. I've got about 6 more cases here, so I guess we'll pass it off to Vernon then.
Yeah, no, thank you so much, and I apologize, Shri. But maybe we'll catch you on another webinar. How's that? Save these are really good. I appreciate the time you put into these.
No problem.
Very informative and thought-provoking. So Vernon, we're going to finish up with you here. Dr. Pace is from Dartmouth, and he's going to be talking about pregnancy and stones. Thanks, Vernon.
Thank you. All right, can everyone see my slides okay?
Looks great.
Hello? Okay, very good. Thank you. All right. Well, thank you for the invitation, and sorry to be so tardy. Few challenges encountered in endourology are as anxiety-provoking to both patient and provider as kidney stones complicating pregnancy. I found the best antidote to the anxiety is a handful of practical points, which I'll briefly share with all today. My sole disclosure is equity in sauna motion. First piece of the information that's helpful both to a provider as well as to the account patient. It's a little bit of information about the epidemiology. And it's important to know that stones are the most common cause of non-obstetric hospitalization for pregnant women. Prevalence of it, which is what families always seem to want to know about, the estimates widely vary. Traditionally, it had been cited at somewhere between 1 in 200 and 1 in 15 pregnancies are complicated by stones. But from just this month's Journal of Urology, a claims-based analysis, Stanford put the number at really the highest recorded to date of 1.6 out of 200 pregnancies in the United States. In the United States, most frequently, these are encountered in Caucasian women. The majority present in the latter half of gestation, and typically women with stones during their pregnancy aren't your recurrent stone formers. 3/4 who have a stone during pregnancy are presenting with their first stone. Overall, in theory and classical teaching, is that there is no increased risk of urolithiasis during pregnancy, but anecdotally, certainly women have recurrent urolithiasis that just occurs during their pregnancies, and many others recount a lifelong recurrent stone history that began intra or postpartum. And there's certain dangers associated with pregnancy that may predispose to stone forming during pregnancy. First and foremost is the hypercalciuria, which we see during pregnancy. This is a result of increased placental production of 125 vitamin D, leading to increased GI calcium absorption. And as noted here, women during pregnancy are found to have an exaggerated response to a calcium tolerance test. The increased GFR also leads to decreased tubular calcium absorption. Additionally, during pregnancy, we often encounter a very elevated urinary pH. And this is likely related to the decreased pulmonary residual capacity with an increased respiratory rate and tidal volume, subsequent increased minute ventilation, and ultimately a mild respiratory alkalosis, which is normalized by increased renal bicarbonate secretion. So we have both increased calcium in the urine and an increased pH, which is a setup for calcium phosphate supersaturation elevations. And indeed, upwards of 3/4 of stones during pregnancy are calcium phosphate when analyzed. Interestingly, the supersaturation increase we see with calcium phosphate seems to persist for decades in multigravids in some data that is was due to be presented at the now virtual 2020 AUA from Vivian Paredes. So let me turn to diagnostic considerations. And we get a little bit of guidance from the American College of Obstetrics and Gynecology regarding diagnostic imaging during pregnancy. They note that X-ray exposures less than 5 rads are not associated with increased fetal anomalies, and thus concern over the effects of radiation shouldn't preclude medically indicated imaging. But during pregnancy, if we can image without ionizing radiation, that should be our first consideration. And thus, ultrasound is our first line imaging during pregnancy. It's readily available. There is no radiation. However, it is highly user-dependent. It will be tech-dependent. And we cannot reliably image the ureter, so we have to depend on the secondary signs of obstruction. Sometimes we do see things nicely. On the left, I have an image of a transabdominal ultrasound where a very persistent tech was able to trace a dilated ureter to the echogenic stone on the right of the screen. And additionally, we can employ transvaginal ultrasound to help identify distal ural stones, as is nicely demonstrated on the right with the transvaginal probe in the upper right corner of our screen, the bladder in the lower left, and the stone in the distal ureter seen at the arrow sign. Well, what other technical adjuncts can we use with the ultrasound to help discern obstruction? I like to take the renal resistive index into account, and the resistance increases with collecting system obstruction. So the resistive index is can be auto-calculated on most current ultrasound machines, but it's simply the difference between the peak systolic velocity and diastolic velocity divided by peak systolic velocity. And in this study from 2000, 22 women with unilateral obstruction from stone during pregnancy were evaluated. And we can see that the resistive index is elevated in the obstructed kidney at 0.69 compared to the contralateral at 0.63. That 0.06 difference was highly significant. So 0.06 was the difference, or the delta RI with the unilateral obstruction in pregnancy. And in comparison, women who had both kidneys imaged without obstruction in pregnancy, the difference was an order of magnitude smaller. And similarly, in non-obstructed and non-pregnant women, we see the same 0.006 delta RI. So a delta RI on the order of 0.06 or greater is very suggestive of obstruction. Of course, this is what we're most used to in terms of diagnosing stones, and these can be done during pregnancy. And there are protocols that are in existence for performing a CT that are well below the teratogenic effect threshold. However, the risk of malignancy remains undefined, and so because of that, I think we still need to exercise good clinical judgment in selecting the patients who are really going to benefit from this CT, as studies have shown that 25 to 50% of those with high clinical suspicion of stone who get a CAT scan actually don't have one. So once we've diagnosed the stone, what's going to happen to it? Well, the reported passage rates for stones vary widely between 60 and 80%, but those prior studies used relatively loose criteria for what might be a stone during pregnancy, using much stricter definitions, having radiographic confirmation or stone analysis to confirm that a stone was present. Dr. Cranbeck's group in 2011 reported that the spontaneous passage rate was closer to 48%. So roughly half of these patients are not going to pass their stone. With that in mind, what do we do with these stones once we confirm that they're there? And the most important guideline statement 54 is that any medical and any surgical intervention should be coordinated with the treating obstetrician. In pregnant patients with ureteral stones and well-controlled symptoms, we should offer observation as the first line because, again, optimistically, 50% will pass these stones. And finally, we may offer ureteroscopy directly to these patients who fail observation. The guideline notes that stent and nephrostomy tubes are alternatives, but I think it's important to recognize that these are alternatives and upfront ureteroscopy is quite reasonable. Downsides of stent and nephrostomy tubes are that they, because of the elevated supersaturation of calcium phosphate, we frequently encounter incrustation on these, and that thus mandates that these tubes are changed much more frequently than in other situations. Ureteroscopy technique is largely the same as ureteroscopy in pregnant patients, but I would propose that there are three big differences that we need to take into account. Considerations for fetal monitoring, positioning of the patient, and the intraoperative imaging. The American College of Obstetrics and Gynecology committee opinion again provides a little bit of guidance for us. If the fetus is pre-viable, you can simply obtain fetal heart tones preoperatively and postoperatively. However, if the fetus is viable, then simultaneous contraction monitoring is also recommended to be performed with fetal heart rate preoperatively and postoperatively. Finally, intraoperative fetal monitoring may be considered if first the fetus is viable. Importantly, there's an obstetric surgeon available to intervene if the monitoring suggests fetal distress that may mandate delivery. And this applies to procedures where it's physically possible to monitor during the operation and the nature of the operation would allow safe interruption. I would argue that in these cases that the nature of the operation ureteroscopy, we can stop safely if we need to interrupt, and that it is physically possible to monitor. So in those cases, as long as the obstetrician is available, we should do that once patients reached viability. Surgical positioning during pregnancy. Well, we want to try to accomplish left uterine displacement. A left lateral decubitus modification with the right hip and right flank elevated about 15 to 20 degrees will roll the gravid uterus off of the case, stable depression. If you're considering fluoroscopy for intraoperative imaging, make sure that roll is radiolucent. And again, fetal monitoring may help guide adequacy of that position by assessing for adequate fetal perfusion. For intraoperative imaging, many different management strategies have been advocated. Our preference is intraoperative ultrasound, which I'll speak about for a moment, but certainly low-dose fluoroscopy with a variety of shielding options, and no imaging, but simply following wire and direct vision ureteroscopy have all been successfully reported. With intraoperative ultrasound, we place the transducer against the patient's flank or upper abdomen. And as we can see in the image on the left, the safety wire can be directly visualized to confirm that the wires are in place. If we are addressing renal stones at the same time, we can directly visualize the ureteroscope, and then you can confirm appropriate stent positioning, all with ultrasound. And then finally, a brief note about obstetric complications that may occur with any stone treatment. Simply with expectant management, there's been reported a 7% risk of preterm premature rupture of membranes, and the odds of a preterm delivery are increased 80% if the mom is admitted with heart. Simply placing a stent incurs at 10% risk of preterm labor within 24 hours of stent placement from a single institution case series, and uroscopy is associated with a 4.3% risk of preterm labor, including preterm delivery when that preterm labor has occurred in the third trimester. So to summarize, it's important to remember that kidney stones are a very common cause of non-obstetric acute pain. Many will be unable to pass their stones. Ultrasound currently should remain our mainstay of diagnosis, and keep in mind both transvaginal and Doppler techniques to maximize what we can achieve with ultrasound. CT can be useful in select patients, and both temporizing and definitive intervention are available for us. Absolutely, ureteroscopy can be safely performed during pregnancy, but we need obstetric complications for 4 to 10%. Preterm labor can occur. Thus, second trimester is the preferred timing for intervention. And I think all of these points really underscore the need for a multidisciplinary approach with obstetric services immediately available. And with that, I will conclude. Thank you for your attention.
Thank you so much, Vernon. I got a question for you. Do you have a recommendation regarding flexible versus semi-rigid? Obviously, semi-rigid would probably be your first go-to, but do you have any problems using flexible pregnancy stones?
No, in general, the ureter is relatively relaxed, and I haven't encountered any of the problems I would have envisioned you might with the uterus in the way. But generally, both flexible ureteroscopes and semi-rigid are able to navigate usually pretty reliably.
Mm-hmm. Okay, great. We've got a couple minutes left here, so there are some questions here that are being thrown out there. And if there's any panelists that want to make a comment as a follow-up to your talk or other talks, feel free. Actually, it looks like we've answered most of the questions here. There's one other poll out there on the shockwave, so if the attendees could take a look at that, we would appreciate it. There was a question about the resistive index and how do you use that? Vernon, can you comment on that?
I will have an ultrasound check ahead of time if they can have that set up for me, and they automatically calculate. They put up their Doppler waveforms. They area interest on the ultrasound when the cursor just is placed over the control, and that's able to then automatically calculate it. Which is, as we know, 70 to 80% of women in life expectancy are going to be developing right-sided hydronephrosis, which may simply be related to pregnancy itself. And that help obstructed hydronephrosis from the physiological.
Yeah. There's a question from the audience here. It says, in intra-op ultrasound, I can typically visualize the guide wire, but sometimes visualizing the stent in the collection system is difficult. Any tricks besides getting better at ultrasound?
Certainly, walking and scanning with the ultrasound to try to catch the plane of the stent can be leaving the wire through the stent a little bit longer and using that to wiggle the stent a bit can sometimes be helpful to see the stent a little bit better as well. But yeah, it's not the imaging we want, but I suppose leaving the wire is probably the most helpful trick I found.
Here's one for the other panelists. Anyone wants to take this? Matt or Seth or Ojas, any preference of a double J stent or a nephrostomy tube for a pregnant female after 24 weeks, or before 24 weeks and after 24 weeks? How does that change your management as far as nephrostomy tube versus double J stent? Any comments?
Yeah, I think it's a tough question. I think what you're referencing to is the fear about preterm labor, and as the uterus gets bigger and the baby starts to get sort of settled into the pelvis, that there may be worsening symptoms or irritation of the uterus that could potentially lead to a preterm delivery. And I think pregnant women don't like having nephrostomy tubes either. So it's always a tough decision. In either case, they really need to be more often, in every 4 weeks. I at least do the first 4 weeks. And then if it's less than expected, then sometimes you can get out to 6. But I sort of plan and prepare the patient for changing every 4 weeks if we're going to try and do that and push out definitive treatment. But I also think that because they tend to have issues with the tubes, as they get further in the pregnancy, we oftentimes, if they're tolerating the stent poorly, will start to talk about definitive treatment. And there's a role for a quick ureteroscopy to clear a stone out of the ureter if you're going to put them to sleep, and try to do it without fluoro. But yeah, it's challenging, I think. But the data are mixed. Certainly we worry about preterm labor, but I think that the risks are less than often, at least for our OBs here. They tend to be less worried about that.
Mm-hmm. And can you comment on another question about CT, Matt? What do you think about low dose CT on pregnant women? Use them, and if you do, can you tell us about your practice with it?
Yeah, that's a great question. I think I tend to not make, I tend to try and really approach this with shared decision making, because I think every pregnant woman has different fears. I think there are some that are very worried about anesthesia. I think there are others that are very worried about x-rays and fluoro and radiation. There are others that are very worried about the amount of narcotics that they're having to consume to tolerate the obstruction or tolerate the stent. And I don't think that often their choices they vary a lot. In general, my opinion to what Vernon presented, we try to start with ultrasound. If you can't see and you're suspicious that there could be a stone in the distal ureter, then transvaginal ultrasound is something that we'll sometimes ask the to employ. And once you get past, and I think the resistive index is also something that can often be very helpful, deciding between the dilation and hydropregnancy when it's on the right side versus a stone. Challenging. But I think that at least at the University of Washington, we've had a low dose protocol that actually we've shared a bunch. And so there's a number of institutions that have the same protocol. The radiation exposure from that is really low. And it's certainly better than other things like MRI. MRI really struggles to see stones, even though there's no radiation with it. There are some protocols and some folks that believe that there's some data that MRI might get better. But I think that, if you need a definitive answer, a low dose CT is totally on the table. And my experience has been that we worry about it when the OBs do. But nonetheless, I think it's something to have in your armamentarium. You got to talk with the patients about it.
Yeah. And, our radiologists say that a low dose CT is not much more than a KUB when you talk about radiation exposure. So in the second or third trimester, they feel like if it's going to change your decision making, then it's not unreasonable to do it.
Yeah.
If you're just going to go up there either way, then they don't recommend it.
Yeah. Our protocol that we have is BMI based. And so it does depend on, the patient's just a little bit more. BMI gets higher, but it's somewhere between 0.8 and 1.2, depending on what your BMI is. And so BMIs over 40 are looking at about 1.2 millisieverts. Some of the radiologists feel like the determination of a distal ureteral stone, because the pelvis can be more confusing, harder to follow the ureter, harder to figure out, if it's a definitive stone, they'll do just a little bit more than that. But yeah, KUB is like in the 0.6 to 0.8 range. Chest X-rays are about 0.5, somewhere in that ballpark. So it's very low dose.
Yeah. Well, listen, I want to thank all speakers, Dr. Pace, Dr. Lang, Dr. Shah, Beaches, Dr. Sorensen, Dr. Sivalingam. Thank you for your time. Thank you again to all our sponsors. Again, if you want to join us this Thursday, we will have our fourth webinar. Starts at 5 p.m. Eastern Standard Time. We'll be talking about supine as well as prone PCNL, ultrasound-guided PCNL if you want to learn from Dr. Chi. And we're going to be covering many different aspects of tools that are available and tricks for PCNL and how to get access. So please come join us 5 p.m. this Thursday, Eastern Standard Time. Go on to www.endoedge.org. Again, that's www.endoedge.org. And thank you so much for joining us. This concludes our webinar. Thanks, everyone. Take care.
Thank you.
Thanks so much.
Take care, guys.
Thank you.